So the International Association for the Study of Pain defines pain as being both a noxious sensory and emotional experience. So psychology is actually integral to the experience of pain, but we don't often treat it that way. And so my work and my talks and the books that I write, I advocate for greater appreciation of the psychosocial dimensions of the pain experience, because these are often ignored, undertreated, and are important therapeutic targets to help our patients reduce pain and suffering, and ultimately need for various treatments, including opioids. Pain catastrophizing, or what I like to call a negative pain mindset, is when individuals will have difficulty focusing on anything but the pain and how awful it is. This is natural and understandable, particularly in the context of severe pain and ongoing pain. But it's important that we equip individuals with various skills to be able to reduce the distress that pain causes, because when it's left untreated, it actually feeds back into the pain experience, amplifying pain and treatment needs. So while it's understandable, we need to pay attention to it and address it. Placebo is a belief that something will be beneficial, a treatment will be helpful. And in fact, when individuals believe that or expect that a treatment will be helpful, it is more likely to be beneficial and helpful. And this is the case in terms of pain, that expectations can confer analgesia. This is placebo. Similarly, on the flip side, if we believe that something will increase our pain or be harmful, this is what we call nocebo, belief that something will be of detriment to us. And these nocebo fears are quite salient in a climate where there is rapid opioid reduction, forced tapering, or even if an individual just simply has ongoing pain and has a negative expectation that that pain is likely to worsen. In all three of these examples, it's important that we identify the nocebo beliefs and thoughts, and that we address them so that individuals aren't unwittingly amplifying pain and distress. The most important piece of advice that I can give primary care practitioners is to introduce your patients to the full definition of pain, to introduce your patients to the role of psychology in the experience and treatment of pain, to normalize psychological treatment, psychological strategies as being empowering strategies versus, a treatment of last resort, because that leads patients to feel judged or blamed, or that they did something wrong when nothing of the sort is true. In fact, in that case, we have failed the patients by not introducing psychology, behavioral medicine, and self-management strategies as early on in the process as possible. What the data tell us are that when we integrate psychology on the front end of treatment, it allows patients better treatment response to all of the medical treatments that are tried later. So we're setting our patients up for success.